right, so it looks like folks are rolling in. So welcome everyone to another Department of Medicine Grand Rounds. Just as a reminder, if there are questions or comments throughout the talk, please feel free to put them in the Q&A or in the chat, and I will monitor them. And I'm happy to have Dr. Rudy Rodriguez introduce our wonderful speaker for the day.
Hi, everyone. First, I just wanted to thank the UW Committee on Minority Faculty Advancement and the Department of Medicine for sponsoring the virtual visit. This is Dr. Cervantes' third talk in the last 2 days here at UW. It's a good way to mark the end of Hispanic Heritage Month, which ended yesterday. Dr. Lilia Cervantes is currently an associate professor of medicine in the Division of Hospital Medicine and BGIM at the University of Colorado at Denver Health. She's a first-generation Latina and a University of Colorado lifer. That's where she received her MD, did her intern and residency, and a Master of Science in Clinical Science. She's been a hospitalist at Denver Health Medical Center since 2008. I actually met Dr. Cervantes about 6 years ago when she decided to pursue her current journey into research and a life of advocacy. I'll let her tell her story, but Lily, just want to tell you how proud we all are of your accomplishments over such a brief time. I'll turn it over to you.
Thank you. Thank you so much for the warm welcome. It has been so much fun to hang out with you guys these last 24 hours. To begin, I have no conflicts of interest and nothing to disclose. For this presentation, what I'd like to do first is describe the provision of outpatient dialysis in Colorado and also in the country. And then I'll move on to describe some of my own research. And I'm specifically focusing on just those articles that I think made an impact here in Colorado. And then I'll briefly describe the advocacy approach that expanded access to care for undocumented immigrants. And before we start, I just want to thank the patients for being my partners in this journey. And it is honestly because of them that this research and advocacy was possible. This picture includes some of our patients and stakeholders celebrating. Hilda, the woman that you see pictured here with her boys, was the inspiration for all of this work. Hilda was an undocumented immigrant, single mother of 2 elementary school-aged boys, and I got to know Hilda very well. She became a close friend because as a hospitalist, I saw her on a weekly basis when she came to our hospital on the brink of death to receive emergency dialysis. After about 2 years of this type of care, Hilda had suffered about 3 cardiac arrests, and her boys were facing significant psychosocial distress. They did not want to leave her side and were missing school because they worried that their mom would have another cardiac arrest and no one would be around to call an ambulance. And so, realizing that her days were numbered, Hilda decided to preemptively withdraw from dialysis. And so I worked with her to find an adoptive family. We interviewed several. And once she found the family that she was happy with and had gone through the foster to adopt process, Hilda stopped dialysis and she passed away on Mother's Day in 2014. And so for me, caring for Hilda as a hospitalist and friend completely changed me. And I found it too morally distressing to continue to provide this type of care. And so this was when I decided to transition to research as a means to change health policy. In Colorado, there were about 120 undocumented immigrants at the time with kidney failure. And at Denver Health, we provided care to the majority, so about 70 to 80. Emergency dialysis looks differently in each state. And so I want to just take a moment to describe what it looked like in Colorado. In Colorado, patients came either through the emergency department or our urgent care center, and they had to meet both objective and subjective criteria of critical illness. This meant they had to have a certain potassium cutoff, they had to be severely ill from their uremia or need oxygen requirements or have some kind of EKG abnormality. And if they were critically ill, they were admitted to the hospital and either to the intensive care unit or the inpatient medicine floor. and they received dialysis that day, were admitted overnight, and received a second dialysis session. And after discharge, they basically had to repeat the cycle 6 to 7 days later. But what happened is we had just 10 dialysis chairs at the time, and the number of patients was increasing. And so oftentimes we had to turn people away from the ED if they weren't sick enough. And this was really hard for patients and really hard for the clinicians. This type of care was extremely expensive. The DRG flat rate on this type of care was about $6,200 per patient per inpatient admission. And compare that to Medicaid reimbursement for standard dialysis, which in Colorado was about $700 a week. And so I realized that in Washington, undocumented immigrants have access to standard dialysis. And so I want to just briefly show you this video interview. The patient that you'll see in this video came in super short of breath, and you'll see the distress in her emergency medicine provider. She had a potassium of 8.2 that visit. She had and I think she had some kind of an arrhythmia. I can't remember what type, but she was sent to the intensive care unit right away. And you'll also see her son in this video. He was in high school at the time, and 11th grade, and was basically missing school to be with his mom.
To really understand what's going on here,
That feel right?
you're going to need to suspend disbelief.
They do dialysis every day?
Lucia is dying, her lungs drowning in fluid, her electrolytes are fluctuating wildly, and her heart is precariously close to shutting down. This 51-year-old mother and undocumented immigrant has end-stage renal disease, full-on kidney failure.
The function of the kidneys is to filter blood of excess toxins and excess fluid. When both kidneys stop working, people on average will live anywhere from 10 to 14 days. And so to continue living, you need some process to filter blood, which is a dialysis machine.
For most people, that treats the problem. But here's the thing. Lucia is allowed treatment only when she essentially arrives at death's door. The Emergency Medical Treatment Act of 1986 says hospitals in the United States must care for anyone with a medical emergency, regardless of their citizenship or ability to pay. But they are not obligated to prevent that emergency from happening in the first place.
What is happening inside the body?
For these patients, because they only come in once a week instead of the 3 times per week, excess fluid, it stays in their body and it goes into their lungs, goes into their legs. Separate from that, the toxins build up. One of the most important toxins being potassium, which at high levels can make the heart stop.
This is no way to live, about as close to death as you can get. And what's more, research shows that treating patients with emergency dialysis versus standard dialysis is nearly 4 times more expensive because these patients, like Lucia, are so much sicker when they come in for treatment.
They're literally pushing themselves to the brink of death
They are.
to get this treatment. Am I overstating that?
No, not at all.
There is no question it works.
Lucia?
Just look at Lucia now, after dialysis removed 10 liters of fluid from her body.
How are you feeling?
Ahorita me siento bien.
Right now, I feel good.
Still, Lucia is always worried, mostly about her family, especially her son, Alex. He watches his mother steadily decline every single week. This is their life.
How hard has this been on your family?
Ha sido muy duro.
It's been really hard.
Muy duro para mi familia.
It's been really hard for my family.
Peor para mi hijo.
The worst is for my son. He worries about me.
Because just a few days from now, like clockwork, Lucia will once again go to the precipice of death, just so that she can live. Dr. Sanjay Gupta.
And so, as you guys saw in that video, her family is also really suffering with her. Her son has just graduated from high school, but it took him an extra year because he was coming to the hospital with her each week. And so nationally, there are about 6,000 to 9,000 undocumented immigrants with kidney failure in the country. They tend to be Latino, male, employed, and the majority have been in the US for at least 5 years before being diagnosed with kidney failure. As many of you know, kidney replacement therapy is the standard of care for persons in this country, and that's widely available because of the Medicare End-Stage Renal Disease Entitlement Program. However, for undocumented immigrants, care varies throughout the country. Immigrants make up almost a third of the uninsured in the country, and I'll briefly go over this timeline to give you a sense of healthcare legislation as it relates to access to care for undocumented immigrants. Starting on the left, the 1962 Migrant Health Act included primary care services for undocumented immigrants and led to the creation of federally qualified health centers. And then in 1965, the Social Security Act amendment established Medicare for older adults and Medicaid for people from lower income. And because it didn't directly address the availability of benefits to non-citizens, many interpreted the statute to allow coverage. But then in 1986, the Omnibus Reconciliation Act explicitly prohibited undocumented immigrants from public benefits. And then that same year, the Emergency Medical Treatment and Active Labor Act prohibited refusal of care in an emergency situation, regardless of immigration or insurance status. And that essentially sort of created the emergency Medicaid programs. And then the Welfare Reform Act of 1996 further restricted immigrant access to public benefits because that required immigrants such as green card holders to be in the US for at least 5 years before qualifying for public benefits. And then more recently, the Affordable Care Act excluded undocumented immigrants, and so they can't sign up for private health insurance on the marketplace exchange. And then because of the public charge rule change, we have seen a decrease in the number of insured children because of fear of the public charge rule change, which basically weighs any use of cash and non-cash assistance against applicants for permanent residency. And so in summary, undocumented immigrants are excluded from Medicare, most Medicaid programs, and the provisions of the Affordable Care Act. And so to receive care, many of them have to go to the hospital and get dialysis that way because it's the only way a hospital can be reimbursed is through emergency Medicaid. And so I want to just take a moment to read EMTALA, the Emergency Medical Treatment and Active Labor Act. It states that federal emergency Medicaid dollars will be allowed only when a medical condition is manifesting itself by acute symptoms of sufficient severity, such that the absence of immediate medical attention could reasonably be expected to result in placing the patient's health in serious jeopardy, serious impairment to bodily functions, or serious dysfunction of any bodily organ. What is interesting and isn't widely known is that the Office of the Inspector General and federal CMS provide no subregulatory guidance defining a medical emergency condition. They actually instead defer to states to determine those qualifying conditions. And so some states like Washington have modified the emergency Medicaid definition to include other things. And so this is the eligibility for your state. It includes cancer treatment and outpatient surgery in addition to dialysis treatment. But as you can imagine, because of what I've described, it's kind of resulted in a patchwork safety net with variation in terms of eligibility throughout the country. This US map that I'm showing here is from data in 2019. I reviewed the Emergency Medicaid Manual and Billing Manual for all 50 states and connected with at least one clinician in one of the major cities in each of the 50 states. And so in this map, the states that you see in green are where Medicaid provides reimbursement for standard dialysis. And then those states that you see in orange are where there's sort of variation. So some cities might provide access to standard dialysis, or standard dialysis is reimbursed in a different way. And the states that you see in red are where undocumented immigrants continued to rely on emergency dialysis. And so after a lot of soul searching, after Hilda had passed away, I decided I needed, as I mentioned, to transition to research, to change health policy. And because that was my purpose, I began by engaging various different types of stakeholders early on. I connected with stakeholders, like patients is where I started. And we met every other week, and eventually the patients created their own peer support group that they called Club Riñones Latinos, and they even made their own Facebook group, which was incredible because they wanted to support other undocumented immigrants throughout the country. And they themselves became engaged in the research and with media and health policy. And as I engaged each group, I also conducted qualitative research. So this study, I connected with 20 undocumented immigrants and interviewed them one-to-one. And I'm going to now just briefly describe each of the themes and provide one of the most important or illustrative quotes. In this first theme, patients described a distressing symptom burden and unpredictable access to emergency dialysis. And so, as I mentioned, patients received dialysis 2 days in a row, but then couldn't receive dialysis for another 6 to 7 days. So maybe they felt okay for 3 days, but then their symptoms just started to slowly accumulate until they had to come to the emergency department. And because they couldn't sometimes be sure if they'd be admitted for emergency dialysis, many of them risked death to meet admission criteria. So they would consume foods high in potassium just outside of our hospital doors and then come in, risking coding and being really ill. So one patient said, "You cannot explain your illness. You arrive in bad shape. You need to have a high potassium," or they send you home even though you feel you are dying. Sometimes you crawl out when they decide to not do dialysis. You eat a banana because it's high in potassium even though you may die, and you go back and wait and hope that they will do dialysis. The second theme centered around death anxiety. As I met with patients similar to Hilda, many of them had had cardiac arrest, and so they described these experiences in a very matter-of-fact way. And they also described witnessing their peers be coded, either in the emergency department waiting room or in the dialysis center. And so one patient said, "I've had people pushing on me right here, my chest. I think it's happened 3 or 4 times, but I don't remember much except that my chest hurt a lot afterwards and my family thought I was dead." The third theme centered around family. What was interesting is that as I met with patients and asked them about their experiences with this type of care, many of them described it through the lens of their families, because for many Latino patients, family comes before self. And so they described hiding in their rooms as soon as their symptom burden started to increase, because they knew that their families would be distressed seeing them short of breath or not feeling well. And a couple of patients described how their own children had tried to commit suicide because of the, significant psychosocial distress this caused them. And so one patient said, "Sometimes when I feel really bad, I tell my family to not pay attention to me. I go to my room and I fall asleep." In the fourth theme, patients described sort of perceptions of the healthcare system. And what I found is that, similar to the connection that Hilda and I had, a lot of patients felt this way about their clinicians. They expressed gratitude for their clinicians. They expressed valuing their clinicians. They knew that we were compelled to provide this type of care and that there was nothing we could do to change it. And so one patient said, "We become very close with the providers and we are appreciative of all the people that work here. We love them." The second study I wanted to go over included semi-structured qualitative interviews, but this time it was with 20 caregivers of patients. And for this one, I'm only going to describe 2 of the 4 themes that we identified. And caregivers here basically described that same sort of anxiety about the unpredictable access to emergency dialysis. But what was interesting here is that many of them felt like as soon as they were accepted for emergency dialysis, they could sort of take in a deep breath and, feel relaxed. Otherwise, they felt like they were sort of anxious the entire time, wondering if their loved one would die or if they would not be admitted for dialysis. And for those caregivers that stayed with the patient, throughout the admission, they felt like they kind of lived at the hospital because they were also staying in the hospital once a week. And so one caregiver said, "I'm practically hospitalized too. The days that she has dialysis, I do not go to work early. I stay with her until she wakes up and then drop her off at the emergency department. Once she tells me she's connected to dialysis, I know the schedule and I try to be there when she's done with dialysis." And then the second theme that I'm describing today is centered around children. Many of the patients are young, they're in their 40s, and so many of them have children, and their caregivers tended to be their spouse, and so many of them described how this type of care had impacted their kids. A lot of the kids, just like Alex, the son that you saw in the video, were missing school, and they were missing school because they wanted to provide language interpretation, or they wanted to make sure that their loved one was going to be okay. And many of them also had to drop out of school to start working because of finances. And so one caregiver said, "My daughter had to drop out of school to help us. She was studying and had to stop and work. She wanted to keep studying, but how will we pay for this illness?" And in this last qualitative study that I wanted to share, I interviewed interdisciplinary clinicians. I explored their perspectives and interviewed 25 at Harris Health and 25 here in Colorado. And they were interdisciplinary, so anyone that took care of these patients, such as social workers, palliative care physicians, cardiologists, nephrologists, everyone. And in our first theme, clinicians basically described several drivers of professional burnout. They described emotional exhaustion from witnessing needless suffering and high mortality. Many of them described feeling like they were jeopardizing their patients' trust, especially when they had to turn patients away, when they were visibly ill but unable to admit them for dialysis. And many of them described detaching from patients so as to not feel too much empathy. And then there was that sense again of a perceived lack of control over emergency dialysis criteria. And so one clinician says, "The challenge for many healthcare providers is to witness a fair amount of suffering. It invites a feeling of helplessness." In our second theme, clinicians described moral distress because care decisions were based on non-medical factors like immigration status. And they described an overwhelming number of emergency dialysis patients and sort of feeling pressured to process them quickly. So it was sort of like treating patients to get them through to emergency dialysis fast. And so they were maybe missing symptoms or physical exam findings that they would have caught otherwise. And then many of them also described this sense of needing to game the system. They described how patients sometimes gamed the system by, consuming foods high in potassium, but they also described how they themselves gamed the system by over-exaggerating their patients' symptoms to get them emergency dialysis. And so one clinician said, "It's a strong message about how we see patients. Some are worthy and some are not. It's kind of like they're treated like dogs in a lot of ways. It's really very heartbreaking." And in this third theme was really interesting because there was a lot of confusion around the financial incentives. At one institution, clinicians were under the impression that they were making a lot of money from this type of care, while at the other institution, clinicians thought that they were losing a lot of money from this type of care. Regardless, all clinicians felt that this was a waste of resources because, as I mentioned, on a weekly basis, patients had labs, chest x-ray, EKG, and they were seen by 3 separate specialties. And then because of that, there were concerns about sustainability. And so one clinician says, "It feels a little bit like we're part of a system that's manipulating the process to provide an avenue for their care and an avenue that will be reimbursed. We're just a stop in the process to facilitate payment." And similar to myself, I found that a lot of clinicians felt inspired towards advocacy for these patients. And one clinician said, "I really wish that legislators would just come and see. I don't think that they understand how tragic it is. I don't think that they understand how easy this could be to fix." And in this next study, it was informed by some of the questions that health policy stakeholders had. And so for this study, it's a retrospective cohort analysis, and we looked at mortality and utilization differences between undocumented immigrants receiving emergency dialysis in Colorado and those receiving emergency dialysis in Houston, Texas. And we compared them to undocumented immigrants receiving standard dialysis in San Francisco. And this was between 2007 and 2014. And this is our cumulative mortality curve. And so as you can see, the top line are the patients receiving emergency dialysis, and they had many more events than those receiving standard dialysis. Our our mean relative hazard of mortality for patients receiving emergency dialysis was 14-fold greater compared to those receiving standard dialysis. And acute care days was also 10-fold greater. This study was really interesting. It's an observational cohort study, and it was conducted in Dallas, Texas. And what happened in Dallas is several patients were enrolled into private health insurance off the marketplace exchange because a philanthropist was providing funds for their premiums. And so this group followed patients that received private health insurance in addition to those that continued emergency dialysis for a year and looked at mortality and healthcare utilization as well as cost. This is their Kaplan-Meier curve of overall survival, and their adjusted hazard ratio of death was 5-fold greater for patients who relied on emergency dialysis compared to those that relied on standard dialysis. And so this is at 1 year. And then with regards to utilization and cost, they found that those patients that had transitioned to standard dialysis had 6 fewer ED visits per month, almost 10 fewer hospital days per month, and it led to a cost savings of about $6,000 per person per month. And so there were other research projects that I haven't shown you during this presentation, but I've presented the ones that I think were most influential in changing health policy in Colorado. And, basically demonstrated that patients and their families suffer significant physical and psychosocial distress related to this type of care, that clinicians were experiencing professional burnout. Mortality was 5-fold greater at 1 year and 14-fold worse at 5 years. And that savings, it led to a savings of about $6,000 per person per month. And so on one Friday in August of 2018, as I was driving home from the hospital, I got a phone call from one of the lead health policy specialists at Colorado Medicaid. And they were calling to inform me that they had decided to include the diagnosis of end-stage kidney disease as a qualifying condition for their emergency Medicaid program. And I had to stop driving, and I couldn't stop crying. And the policy specialist that called me also was crying. And it was just, incredible, because it had been 5 years of research and stakeholder engagement that led to this health policy change. And so what I'd like to do next is kind of move on and describe some of those keys to success. And I think, from my perspective, sort of the most important driver in all of this is the coalition of stakeholders that became part of this movement. I, as I mentioned, initially began by engaging patients, and they became my partners in changing all of this. They very willingly shared their stories with media and with stakeholders. We also had suddenly a mass of interdisciplinary clinicians, and so it wasn't just nephrology and hospital medicine, there were other subspecialties. And because as clinicians we're not trained in advocacy and policy work, I connected with a lot of folks in advocacy and policy and learned from them and leaned on them on their expertise. We also connected with a lot of Latino-facing community-based organizations. And I should mention that whenever we engage stakeholders, I always started with Hilda's story, because it was just incredible and powerful how a combination of research and coalition building could lift her story to a level where it could produce change. The second piece that was extremely important was gathering all the data. I've described a lot of the qualitative data during this presentation, and to be honest, what I found is that the narratives drew in more media attention than a lot of the quantitative studies that we published on this. And I think that it's because people were really able to sort of understand the suffering and the experiences of the different people involved in this type of care. Second, we conducted an internal cost analysis. And as I mentioned, each time a patient was admitted, we received a reimbursement of about $6,200 to $6,700. And so that was sort of the DRG reimbursement on a diagnosis of severe life-threatening hyperkalemia. And so, compared to Medicaid, again, at $700 per week, that was a huge cost difference. And our hospital was making about $15 million per year just by providing this type of care. And then the third critical piece of data that we gathered was the policy analysis. We needed to understand all of the policies around this so that we could better understand how to change this. We found that state legislation was not necessary. And what we really wanted to do is wait to connect with state legislators because we wanted to expand care for all services for all undocumented immigrants. And so we didn't want to pursue state legislation quite yet for this. We found that we didn't need CMS approval because CMS defers to states to define those qualifying conditions for emergency Medicaid. And state regulation was also not necessary, and it would have led to a lot of stakeholder engagement and ultimately a vote by the state medical board. And it was really just a state billing policy change, which was sub-regulatory language and something that could be done at any time. And once we understood the cost savings to the state, the policies around this type of care, and how other states had changed them, we reached out to our state Medicaid agency and we met with their legal team, their executive staff, the Medicaid director. We presented all of our research, the policy analysis, the cost analysis. And a lot of our internal executive staff actually came to these meetings. And so after several meetings, they decided to make this sub-regulatory language change. As far as the challenges, it was critical to understand the policies behind all of this so that we could more carefully identify the important stakeholders that would be involved in changing this. As I mentioned, the chief financial officer was really important, but one of the initial stakeholders was the executive director of Denver Public Health. He at the time was the director of our directors of service for the hospital, and I had connected with him and shared my concern for this issue, and he brought it up to the directors of service, and they all unanimously voted to assign a committee to look into this. And they actually asked our chief financial officer, Peg Burnett, to sort of lead this committee. And the second challenge was sort of the national anti-immigrant sentiment. And at the time, folks, were somewhat explicit about their views on immigration and access to care for immigrants. And sometimes that came through email. And that was at times tough to deal with. And then lastly, our state Medicaid agency actually initially thought about making the sub-regulatory language change early on in September, but this was rescinded for various reasons. But one of the most important reasons was that this was going to be very polarizing. And at the time, our state governor was pursuing the Democratic nomination, and some thought that this could draw too much attention. And so as far as the response to this health policy change, I wanted to share, how things have changed in Colorado. For patients, this is a picture from this past Christmas, just before COVID. We all got together and the patients looked amazing. I wish I could show you a picture before and after, but they looked amazing. Many of them had started working because they felt so much better. They had lost a lot of weight. They were on less medications because they didn't need as many to control their blood pressure. They were able to spend more time with their families because they weren't hospitalized once a week. And many of them actually ended up getting private health insurance and on the transplant list because they were working enough to be able to afford private health insurance. And to assess the transition from emergency to scheduled dialysis, we conducted a study looking at quality of life and symptom burden and the experiences of undocumented immigrants before and after they transitioned. So this was essentially a pre-post intervention mixed method study with qualitative interviews. And we used the KDQOL SF36 to assess quality of life, and we found an improvement that was statistically significant across all 5 subscales. And we also used the modified ESAS for renal patients and found an improvement that was also statistically significant for 7 symptoms, and identified 5 themes. Patients initially had a lot of anxiety about navigating the challenges in care. They were a little bit fearful that they might face discrimination as they transitioned to the to the freestanding dialysis centers. They didn't know if there would be interpreters there and how they would be viewed. Many of them also worried about transportation because they knew they had to get transportation to and from dialysis 3 times a week instead of once a week. But once they transitioned, many of them described this incredible relief in receiving consistent care. They no longer had to fear being, not accepted by the emergency department. And then separate from that, many of them described the immediate and remarkable health gains. They just felt physically better, and they felt like it restored hope and humanity because they were suddenly able to spend time with their family and friends. As far as the hospital goes, as I mentioned, our hospital averaged about 15 million annually from this type of care. And we had about 2,400 admissions generated by emergency dialysis. Our chief financial officer looked at all the numbers in 2019 and found that we had actually only decreased the number of admissions by 800. And so her takeaway from that was that there was demand for the beds, and maybe we were on divert less because all of these patients had transitioned to outpatient dialysis. And then despite the change in September of 2019, we were on track to meet or exceed our targeted operating income. And so as far as next steps and things going on nationally, there's groups, across the country that are working on advocacy for kidney transplantation for undocumented immigrants. In the state, I worked with our state Medicaid agency to similarly expand the emergency Medicaid definition to include outpatient COVID-19 care for patients. Because at the time, I think it was in March, we were discharging patients and unable to discharge them with oxygen after treatment for COVID-19. And so it was kind of cool to sort of follow a similar algorithm and expand access to care, outpatient care for COVID-19 for the same population. And I've worked with folks in other states that are similarly interested in changing access to care through a similar algorithm, so providing guidance for them. And I am now continuing my research, but focused really on improving social challenges faced by dialysis patients and on reducing the burden of CKD in the Latino diabetic community. It's interesting because before I started this journey, I had no interest in doing research. And at this time, I can't imagine doing anything different because I just see research as such a powerful way of informing policy and in eliminating structural inequities. And so this is a picture of Hilda's boys now. This is from just 3 months ago. Her oldest son graduated from high school and he started college. They're virtual now, but he started college. And so it was just exciting. It's been exciting to sort of see the boys grow and travel and, continue their education. And I just want to end by thanking everyone that's been part of this journey, my family, my patients, the mentors and collaborators, and the funders as well. And so I don't know if any of you guys have any questions, but I can take them at this time.
Thank you so much for such a fantastic talk and really powerful stories of some patients that we can all appreciate their incredible journey, and their incredible advocacy for themselves as well is remarkable. There were a couple questions from the group, and one of them was, is there any evidence of internal immigration of non-citizens with end-stage renal disease to states that cover scheduled dialysis, as in moving from one state to another, if you're aware of any information on that?
I'm not aware of information on that, but we are working with our state Medicaid agency to see if the number of patients has increased since we expanded access to care, because I realize that many states are concerned about providing access to care and then having, an increase in the number of patients that move in. And so we are looking at the number per year that that come to Colorado for this type of care, but I'm not aware of any specifically moving here for that reason.
It'll be interesting to see the results from that for sure. Do you have any thoughts on provision of peritoneal dialysis for this group? As you mentioned, these patients are often younger and have lots of family support, which may make them good PD candidates. Has that ever come up for you?
Yeah, it has. Peritoneal dialysis would be ideal for these patients because they'd be at home and, they'd have a better quality of life. We have not started pursuing that quite yet, but I know that Rajiv Raghavan, some of you may have read some of his work at Harris Health in Houston, Texas. They've started a PD program for undocumented immigrants, and there are a couple of states in the country who provide Medicaid reimbursement for PD for undocumented immigrants. But like I said, throughout the country, everything is different. So some states do it, some states don't. Some states offer both HD and PD and kidney, and so care just kind of varies throughout the entire country. But in Colorado, we are not yet able to offer PD.
Yeah. You alluded to the fact that transplant is even more cost effective than standard dialysis. Any thoughts on the possibility of getting support for things like living donor kidney transplant?
It would be incredible if we could provide that type of care. There's a study by Jenny Shen, I believe published in AJKD, that described outcomes comparing potentially undocumented immigrants to documented individuals. And she found that the outcomes from kidney transplantation were the same. And I mention this because some people worry that providing undocumented immigrants with kidney transplantation could potentially, if patients are sort of unstable and moving back to Mexico, they could stop taking their medications, or maybe they don't have access to the medications and could lose their kidney transplant. So she showed that they had similar outcomes. In the country, I think my perspective is that the first step is to make sure that everyone can have sort of standard dialysis. And then from there, a next step could be kidney transplantation. But that said, Illinois offers it, and there's a group in Virginia that is looking at the cost effectiveness of kidney transplantation. And so this is a group that's doing their own cost analysis on this.
Yeah. Have you or have other states shown interest in Colorado's success story, since it's really a dramatic story and so positive?
Yes, that has been extremely exciting. I worked closely with a couple of states, providing some of their healthcare champions with guidance and mentorship on who to connect with in the state and how to sort of get a sense of the costs and the policies around this. And a couple of states have, I showed that initial map that had a lot of red states. A couple of those states have turned green. And I can't tell you who those states are or which those states are because they want to keep it on the DL. But that has been one of the really exciting experiences in all of this, is sort of connecting with others that also want to advocate for this community.
Yeah, that's phenomenal. So your work is even farther reaching than even just within the state of Colorado, which is phenomenal. People have loved your presentation and are so appreciative, and questions keep coming in. So thank you for taking the time to answer them. Another question from our audience is, in recent months with the change in visitor policies during the pandemic, have you noticed changes in patient admissions or treatment, particularly in this population?
Yeah, and it's something we've been looking at very closely in Colorado. My just clinical experience is that ever since the public charge rule change, we've seen less undocumented immigrants come to our hospital. And it's, it's sad because we are a sanctuary state. And despite that, undocumented immigrants are very scared of seeking care at the hospital. They worry that we'll share their information and they'll be deported. Separate from that, they're of course also worried about the costs. And so during this COVID-19 pandemic, many patients stay at home and they don't end up coming to the hospital until they're really, really sick. And that has been really hard to witness. In Denver, the percent of COVID-19 cases is about 54% as of yesterday, compared to Denver's population of about 16 to 17% Latino. So they're disproportionately burdened for sure, and scared of coming in. And so that, that has been really hard.
Yeah, absolutely. Another really great question for you about kind of your journey as well, as you made pretty impressive career change and have had such amazing work come from that change, is looking back on that path. Do you have any lessons that you learned that you want to share with our trainees and young faculty who might be considering a change in career path, something like you did a few years ago?
Yeah, for me, when I transitioned to research, it was initially hard because I didn't have a strong research background for sure. And so I reached out to various mentors, career mentors, research mentors, and asked for guidance, and joined a couple of sort of junior research faculty development programs to begin to build my research foundation. And I enrolled in a Master of Science in Clinical Science. And so all of that was really important for me. And to be honest, during that first year, there was a lot of blood, sweat, and tears. And I did think about, leaving that path, but I surrounded myself with people that encouraged me and that helped me along the way, that helped me really believe that this was possible and that I could make that transition. And as I mentioned, at this point, like, I can't imagine doing anything different. It's such a, I love what I do now because it's just so meaningful. This past year, or just in the last few months, we received an almost $1 million grant from the mayor's office to reduce the number of cases and deaths in the Latino community of COVID-19. And that was all possible because of my stakeholder engagement with health policy and patients and community-based organizations. And so, this journey of advocacy and of research has, sort of built, into helping me sort of connect, the pieces between government and research and the community, which has been really exciting.
Absolutely. And in that vein, for those junior trainees or residents or faculty who are interested in advocacy, do you have any particular words of wisdom for those looking to get involved?
Yeah, if you're interested in advocacy and policy, there are a lot of national groups now that offer training in advocacy and policy and mentorship. Actually, even in medical schools, there's a lot of programs that have popped up. And I think some of this could be because, some would say the last 4 years have been kind of difficult and these are unprecedented times. And it's, I think many of us feel motivated to advocate for marginalized groups. The other thing I would say is if you're working with marginalized communities, the principles of community engagement, of community-based participatory research are really important to understanding how to address inequities. And separate from that, I have found qualitative research to be extremely important because it is, a different way of connecting with marginalized groups, because oftentimes there's a power dynamic and they can be distrusting of you. But if you spend the first 5 to 10 minutes connecting with them and developing rapport, then all of a sudden you have, you get to like the real information from that patient or the real data. And so that, those are, I think, important pieces, but also know that you are not alone. I mentioned earlier that as a minority physician scientists doing this type of work, you can sometimes face adversity because there is a very strong anti-immigrant sentiment throughout the country. And so, find people that will support you and guide you and lift you up when things are difficult.
Yeah, that's, I think, wonderful advice as folks are looking for ways to how they can be more engaged and advocate for their patients and for marginalized populations. And you've done such incredible work. It's truly an inspiration. And folks are the common thread of the comments are just how wonderful and amazing the work you've done and how inspiring this work has been. So thank you so much for sharing and taking the time to share with us. It really is an inspiration, and I'm glad you made that career change because you've had such an incredible impact on such a huge number of people. So thank you so much for spending time with us and sharing with our Department of Medicine.
Yeah, thank you. Thank you for having me.
Of course. Hopefully we can see folks back same time, same place next week for our next grand rounds. We'll be having it the focus will be on COPD from one of our colleagues at the University of Pittsburgh. So hopefully we'll see you all there. And again, Dr. Cervantes, thank you so much for such a wonderful, wonderful talk and all of your fantastic work.
Thank you.